I'm going to dive in a little bit, talk about Eidos, we're new kids on the block, talk about why we're here and why this topic. And then I'm going to turn it over to my wonderful colleague, Patrina, who's going to do a little bit of scene setting and ground us in a little bit of Patrina's research into this topic. And then we'll turn it over into a conversation. Then Kevin will come back behind the scenes and corral us all into separate breakout rooms where we can maybe have some smaller conversations and really talk to our panelists, which will be really lovely. Okay, so let's see if I'm going to embarrass myself or not by sharing my screen correctly. And let's see, Jessica Halem, can she do it? She did. Oh, Jessica Halem. Ugh, just earned my keep today. So let's dive in. I like to start off embarrassing our faculty director with this beautiful picture. It's not embarrassing. I didn't mean to say that, but he's not here, so I can talk about him. Dr. Jose Bauermeister is our faculty director. He founded Eidos a little over a year ago here at the University of Pennsylvania School of Nursing. We're proudly here housed in the School of Nursing, connecting across the university, across Philadelphia, and onward. Jose's vision was really to link some of what he wasn't experiencing in other areas of public health. We want to link in community experiences, diverse partnerships, thought leaders like the folks we have today, and of course, public health science, all to advance the well-being of the LGBTQ plus community. And how do we do that? We've got sort of a special take on this. I have been involved in LGBTQ health for over 20 years now, proudly so. But we really wanted to add some some other features to the LGBTQ plus health movement. We wanted to bring together the healthcare sectors, government, policy, community, and academia, as well as the business sector. So recently we announced a wonderful new partnership with Gangels, a large venture capital syndicate housed out of New York City. They are the largest funders of LGBTQ startups. We really wanted to try to bring together some of the silos that Jose and I were a little too familiar with in LGBTQ health, try to break down some of those silos. And that's kind of where we're coming at today, right? We've got folks, you'll see in a little bit, that come from different spheres of LGBTQ health. And of course, you all in this audience probably know this data. We love Gallup for doing this poll. Curious if they're going to come out with it again here in 2023. But we've seen this growth of people. Did they? Today?
Yeah, just last week, like Thursday. But the numbers look all about the same. So no
about
worries.
The same. Okay, because the growth, Bianca, was getting a little. I mean, we don't.
It was a lot. It's held steady.
Okay, great. So these numbers, of course, for those of us who work in this field and those of us who are older, I'm a proud Gen Xer. What I always like to say is what we see is a huge shift, a sea change in the ability for people to feel safe and accepted and publicly identified when a Gallup poll worker calls your house, right? Gen X, there's plenty of us in Gen X, there's plenty more millennials, but what we know is that we're really getting this push from the younger generations to maybe perhaps speed up a little bit of the work that we've been working on for a long time. So let's dig into this. More that we can talk about Eidos at another time, but the reason why we brought together these three folks, again, research, policy, and business. It's really an exciting combination that we have for you all today. I couldn't be more thrilled to try to really think about this conversation. We've called it LGBTQ families. We're really going to spend some time now talking about assisted reproduction, or I guess how babies are made. I guess we're going to talk about how babies are made, Patrina. So this is really a dream come true for me to be on a Zoom with you all today talking about how babies are made. So without further ado, I'm going to drive the slides for you, Patrina.
Fantastic. Thank you, Jessica.
Great. You're very welcome.
Let me.
I know it's hard. Right. We've got a lot of pop-ups here.
Here we go. on to research on LGBTQ family formation or family expansion. All right, so it looks like the numbers are in, and there are lots of folks who have been engaged in or involved in family expansion of some sort. My name's Patrina Sexton Topper, and part of my research that I did at Penn in the School of Nursing was about LGBTQ family expansion. I focused on same-sex cis female couples, and so I'm coming from that perspective. And I'd say one of the things I want to note here is the importance of the synergy of business, policy, and research, because as many people here know, research moves at a snail's pace. And if we can jettison things, that would be fabulous. If Eidos can make an impact on jettisoning those things, it would be fabulous. The framework of reproductive rights and justice informed a lot of my thinking and my research. So and this was driven by Black feminists in the 80s who came up with these 3 pillars of the right to have children, the right not to have children, and the right to parent free from threats of harm. And these are all really important when we're thinking about how we expand families. So one assumption that we all should come to the table with in thinking about this is that LGBTQ folks, like heterosexual folks, have authentic desires and aspirations to fulfill family formation. So to have kids, to raise kids. And so that includes bearing children, not bearing children, and being safe when we're raising families. Next. So as with many stats around LGBTQ folks, there are no definitive statistics on the number of parents in the US, not definitive. There are estimates that range between 2 and 3.7 million children under the age of 18 that have LGBTQ parents. And those numbers came out in 2015 from the Williams Institute. And there are other numbers, but let's just set the table with that one. There are no definitive counts on who's conceiving and how they're conceiving and what their success rates are. We can go forward. Thank you, Jessica. And so we'll talk a little bit about my research focused on who is building or expanding what and how. Next slide. So who? People who parent children. That could be individuals, couples or dyads, or multi-partner relationships, people who are co-parents or in romantic relationships. What? The process of adding children. That could be done through fostering and adoption, pregnancy, and surrogacy. What do we need for that to happen? The tools of reproduction, as most people here know, are sperm, egg, and uterus, right? And so we have to consider from whom the gametes come, who has the uterus in which an embryo can grow, and who are the gamete contributors, right? And so when we think about those things, we need to think about the legal and policy implications, economic and access issues. So next slide. And I came to my research with those questions, understanding that many people, not all, but many people do use clinical assistance, which can include working with licensed midwives and other community workers, nurse practitioners, nurse midwives, physicians, and PAs, including, and many nurses who work in this space, right? And so we're interfacing a lot with nurses to do this family expansion stuff. We can do that with intrauterine insemination, medicated IUI, IVF, and co-IVF. Co-IVF is when there's egg extraction from one partner, an embryo is created with donor sperm, and then embryo transfer to the other partner who has uterus and can facilitate gestation. Next. So these are all different ways of doing family expansion. And one of the interesting things is that the market landscape is a growth one. Globally, there are estimates that $36 billion will constitute the industry within a couple of years from now, right? And so we also know in the United States that there's a lot of marketing to LGBTQ folks by clinically assisted reproductive practices across the United States, whether it be rural Kansas or New York City or rural Alabama. This is happening because we know that it's a growth market and people want to tap into that market. The problems are that there are promises of inclusivity and competent care without the delivery always. And so there are practice management issues that need to be addressed. This is a quote from one of my awesome participants in a qualitative study that I did with Jose. And we got really interesting data. But one of the things that people really emphasize is like, my body is fine. I come into this process of trying to conceive, assuming my body is fine. And I don't want to pay for all the ancillary services that come with packages that are delivered by ART physicians, businesses, right? So there are questions about how we do this and what assumptions people come into care with. Okay, so next slide. I think here are the big 3 ticket items that I think would be useful for this conversation here in terms of the research that we've contributed. It's a little sliver of research in a field that is growing. In the last 5 years, we've seen a lot more people engaged in this area of research, and it's really exciting to see. So information gaps exist. So people come and desire to form families, but as one of our participants said, we don't grow up knowing how to do this, right? So there's a lot of information you have to gather, sift through, and then use and employ in order to do this in an efficient way without wasting tons of money, time, the emotional, biological, relational impacts of trying to conceive using clinical assistance, or even trying to conceive with known donors and those dynamics, right? There are lots of things at play that have to be figured out before you start the process, for the most part. And so the outcomes are varied. And then we know that we need to tailor care better for LGBTQ folks who want to try to conceive, do surrogacy, folks who are doing adoption and fostering as well. But tailoring care is really important. And there are a lot of opportunities in the practice management space and policy space to do that. Next. So we need more data. That's it. We need a lot more data on outcomes, who's using what to try to conceive, what the sequelae are to engaging in intensive cycles of care, and how partners and multi-partner relationships and individuals experience that care, and how we can better support folks with wraparound services. Next. And those are some references. Thank you.
Well, you wouldn't have earned your spot here at the University of Pennsylvania School of Nursing if you didn't say more research was needed, Patrina. So you checked that box, but it's so true. That is a recurring theme in LGBTQ health work, right? We really do need to talk about more research, but this area, I am struck by, as someone who has stayed abreast of the research, I am struck by how little there is in this area. So Emma, I want to come to you first. So I will, how about we do some introductions of our other panelists, and then Emma, I'm queuing you up so you can prepare. I'm going to have you go first because I know you've got plenty to say. Bianca, would you introduce yourself for our wonderful crowd?
Sure. Hello, everyone. My name is Bianca Wilson. I'm a senior research faculty at the UCLA Williams Institute, which is a law and public policy, LGBT or sexual orientation and gender identity research center. Speaking to you today from the LA area, from the traditional and unceded territories of the Gabrielino and Tongva peoples. I'm a community psychologist by training, came out of Chicago where I met Jessica, focused, primarily on the ways that systems and culture impact LGBTQ plus well-being. Yeah, so that's a little bit about me. We'll probably talk more about how we come to the work, or do you want me to talk about that now?
Yeah, we'll get to that in a minute, Bianca.
Okay.
You're I'm gonna Emma, you're up.
Hi, everybody. I'm Emma Schwartz Rose, and my pronouns are she, her. I am based out of Los Angeles currently as well, but I'm a Philadelphia native by way of New York for most of my adult life. I have to say all of those things when I say I'm in California. I have spent the last decade in tech, working in tech, startups of varying levels of success and various scale, and focusing a lot over the last 3 years on LGBTQ family formation in online community support and creation of content to build and grow understanding so people actually know how to move forward and make these babies happen. My wife and I welcomed our first child 6 weeks ago. Juno is thriving and is the biggest baby I've ever seen. And so I have both the sort of practical experience of going through this process with my wife for about 2.5 years prior to, as well as a lot of anecdotal research and interaction with large scale online communities who are trying to access the information that Patrina mentioned isn't there, and as well as aren't really being counted, so that there isn't a lot of data to support things. And that's definitely something that I've come up against in the business world as we try to innovate in this space, that there's just almost nothing that you could bring to a venture capitalist or someone in funding where you can't have decades of data to back up any kind of claim. And so it almost feels as though I'm just sort of pulling something out of thin air when I know more, just within my own lived experience and so far beyond, that this is just such a massive space and growing. But again, there's just this dearth, unlike anything else that I've ever delved into before.
I mean, peel that curtain back a little bit for us, Emma. I mean, some of us listening haven't been in those rooms that you're in. So, what is it, Patrina's work points to that plenty out there know well and good. We've got plenty of wonderful people who work in huge healthcare systems in the chat. Plenty of us are trying to change our systems, are trying to grow a business to support this community. What's really going on in those rooms? Why have we not seen more faster?
Well, I think a big part of it is just who holds the wealth. I think just if we look plainly at where a lot of the wealth is held, especially in this country, there aren't a lot of LGBTQ identified folks that don't have large access of personal wealth that could just basically do whatever is needed. And so when that happens, you have to bring someone along on the journey. If I'm going to pitch a concept that I think should be fundable, I have to make someone who doesn't live it really feel it and understand it. And there's a lot of storytelling involved that is backed up by data. And those numbers are what folks who can't relate can relate to. And without that, it feels like half the story. But at the same time, it's like nothing that I've ever pitched or put in front of someone has ever been a bigger opportunity, has ever been more of a growth market, and has ever been so immensely needed. And what I always point to is just if we look at Gen Z and we look at those numbers of 20+% are willingly identifying openly.
Right, exactly.
Queer, which I would say, I don't know, double it, add 15, 20% on top of that easily. They are growing up in a world where they're going to be shocked and appalled by the way that millennials and every generation before who are queer have built and created and sustained their families through clinical care and not clinical care. I think it's just something that when we interview folks who are just in the upper end of the Gen Z generation, and we explain and sort of showcase what's on offer today, they're appalled, they're shocked, and they're having conversations about their queerness and their identity so early on in their life that it is implicit that if they want children and they know that when they're 6, that they're going to expect that that's going to be facilitated for them as they continue to grow. And so the early 20s Gen Z folks that we have been researching with and interviewing are just aghast when they're shown what the interaction is within a sperm bank, how you go about finding a clinic, how do you determine if it's going to be safe care, what do the policies look like, and the fact that I did reciprocal IVF with my wife, and so my daughter is genetically mine, but even in the state of California, I'm going to have to adopt my daughter. And that is bananas, to say the least. But it's something, I think it's where all of these layers intersect, and it warrants how do we completely overhaul and evolve and rethink what family formation looks like if we're not bound by the shame of infertility, by the sort of societal structures that made the whole industry something that was shrouded in secrecy and embarrassment and shame for cis heterosexual couples who weren't able to conceive within their own relationship or without the help of a clinical provider.
Right.
Whereas like my wife and I have always known that we would need an assist. We're not upset about it. There's no shame around it. We're like, let's just make this happen.
Right.
And I think when you see in any market a seismic sea change on what the needs are, you have to reevaluate from the ground up what are the solutions for problems that we didn't know that we had before.
Yeah. So Bianca, the Emma's perfect ending there. The problems. You are a specialist in the problems facing our communities. You are a voice that I have looked to and been inspired by for a long, long time. What do we need to know? I feel like we have a momentum here with younger generations and what they're demanding. What do we need to be paying attention to, Bianca? What does this community need to know?
Well, let's see, a few things. I mean, so something we do at least have some data on, and more recent national surveys include things like the ways that queer folks come to have children in their home. And what we know about that is at the same time, there's clearly a need for investment and thinking and rethinking, as Emma said and Patrina said, about how to create families through different assisted technologies, that nonetheless about 80% of the children in the homes of most queer people come from previous sexual relationships. So, that has to continue being part of this picture, how we talk about this, that these aren't all same-sex folks that are creating families together, and not all with the assistance of reproductive technologies. And there's a lot of class and race differences around that, which kind of brings me to the other main area for me is just a lot of my work is focused on thinking about how issues around system involvement, like incarceration, criminalization, experiences with foster care, and then just poverty more broadly, which is kind of cyclically connected to those prior two topics, are key features affecting the well-being of queer families. And that's both families that exist from previous sexual relationships, but also like a really important factor, which again gets at something Emma was bringing up, that comes up for those who do want to create a family together and could not, have children through a sexual relationship. How do they do that when economic disparities like poverty is such a big feature for queer communities, but again, particularly for folks of color, particularly for trans folks in our community. So, those are some of the things that we have to continue, keeping in mind, and how to really thinking about increasing visibility of the range of families and thinking about what access means across all those different ways that families come to be.
I mean, Bianca, the points that you just made, two really, really important points. The children in our queer families from other relationships, and that poverty ends up creating a huge barrier for too many people who would like to participate in an LGBTQ family. And so where's our FQHCs in this, right? It's like, how can we make sure that our beautiful LGBTQ healthcare centers are thinking about lowering the barriers, or how can we be thinking about lowering the bar for making families? So strengthening those families. I think about all the work that, Patrina and Emma shared, and how quickly we'd move into this, how we need to be cognizant of both of these, the creation of children, and also the bringing of children from other relationships. So thank you for that, Bianca. And thinking again, the poverty part of this, the business sector knows very well that plenty of us on this call could shell out and would shell out a lot of money. Our employers would shell out a lot of money, but that's still leaving a lot of queer families behind. Thoughts, Emma? I know you've been thinking about this. Patrina, did that come up in your work, Patrina, about the economic barriers that families are facing?
100%.
Yeah.
And most of the people that we interviewed to do these in-depth interviews faced really considerable economic challenges. And so I want to circle back to the thing that I talked about at the outset, which is people have desires, authentic desires to fulfill these family aspirations, right? To have children and bear children. And those are across racial and economic groups, right? And the idea here that drove me to this work was considering optimal health. That's a public health mandate. One of the things is fulfilling these deeply held aspirations. People wouldn't go jump through all the hoops that they do to have children unless there was a strong motivation to do so. And in fulfilling that heart's desire, right, that is meeting a really important need in our society, and having that accessible to everyone, and to build families and to have supports around them that contribute to building healthy environments for folks so that they can live optimally. And that's really the driving force here, I think.
And I can even imagine, and thinking about Bianca's points about children from other relationships, building healthy families means having, again, that destigmatizing, no shame about how children come into our lives, all the different parents of past and present, all the different adults of past and present that maybe in a positive or negative, how can we maybe embody some of that? I know that Patrina and Emma, you've been thinking a lot about this around, you love, talking about this destigmatizing, thinking about all the different grownups involved, or people who
I think
don't
if
act
we
like
look
grown-ups.
if we look at the Gallup data and they kind of break down the percentages of folks who are openly identifying, folks who identify as bisexual are by and large like the largest share. And so when I look at that, how I can partially interpret that is that bringing a child from a previous relationship that would have been read as heterosexual into a relationship that would be read as queer or homosexual is going to continue to happen, probably even more so. So if you're a bisexual person and conceive a child with your cisgendered heterosexual sort of like paired partner, then you move into and evolve your life into a new relationship, there's going to be a different set of precedents for what that looks like. It isn't necessarily like you come out now and now you have your child and you're bringing into a new relationship. And so if we bear that in mind, I think that it just expands, and we actually have the data to back up that this is going to be like even more so more prominent than I think in the past. And in general, I think you cannot separate, this is all inextricably linked, the essence of just race and class, and how that lacking equitable access to both care and information in order for queer folks to create their families is just, the current state of it, I'd say right now, is appalling. The fact that people are getting second and third jobs at Starbucks and Amazon just to get healthcare coverage because whatever full-time other job, they're not able to access that. And then a lot of the learning that I've done over the past couple of years has really been arm in arm with the largest queer Black parenting community online that's called EXA, that's run by an incredible founder named Mia Cooley. And a lot of when I had access to do research with folks that I learned is like, not only is there an economic barrier for some, certainly not all, but there is so much more there that would put distance between a queer Black patient or person and wanting to access clinical care and enter a clinical environment ever at all. And so if it's not necessary, how can either we reduce the clinical intervention required for queer folks to conceive their family, similar to how many heterosexual folks can use sort of timed intercourse and other methodology that's much less medicalized, or like how can we ensure that Medicaid can provide the same level of access to care that folks who are in an employer-sponsored plan are able to access. And I think if we just say that it is ubiquitous to fulfill that deep-seated need, then what needs to be in place to both structurally enable that, and then once a person determines do I want to do this in the comfort of my own home? But is there some blood work that I could do ahead of time to learn a little bit more about how to track and understand my cycle? Or how do I get supported using a known or directed donor that may not qualify to be a part of an existing sperm bank? And then I think lastly is when we look at the specific structure of a heterosexual relationship and the way that clinics reinforce that that is safe and good and like less expensive than in a queer relationship to bring in a known or directed donor to do the exact identical process as an intimate partner would, and yet economically you're at a massive penalty just financially what it costs to have someone's cisgendered husband come versus someone's close friend, family member, brother,
right.
cousin, is just an extraordinary barrier to building a family on your own terms that I think is totally changeable without an extraordinary amount of policy intervention, apart from all the other stuff we just were discussing.
Well, let's dive into that. We're going to do a couple more minutes together, and then we'll do some breakouts. But Bianca, you know, we've got interesting people on the call. What are the policy needs here? Where do we need to go? And please take some time to help us also get better at understanding the systems of adoption and fostering in this as well.
Yeah, I mean, there's so many issues just kind of intertwined in here. I mean, I was struck by how many folks on the whole noted kind of discrimination more broadly, but also the legal kind of protections. And I mean, both of my colleagues here, you know, noted the need for, you know, how can we work together to rethink how family is defined? And, you know, in all of its implications for the protections of parents and children and their relationship to parents and other caregivers in ways that don't constantly create more economic barriers for protecting families and, you know, like just the process of, you know, second parent adoption. I mean, these processes are not cheap. They're time, whether it's about cheapness and, I mean, cost in terms of your time on top of the actual legal process itself and the use of attorneys, you know, but also just the kind of stability of our families. And, you know, again, and I say this as someone who's also a parent and parent in multiple ways, blended family, kids birthed, kids not birthed, a child of someone who was in the foster care system. You know, so yeah, there's the legal part in terms of just how our families are defined that needs attention. It varies from state to state. You know, in the US, while we might be thinking about having a federal protection related to marriage equality, that's not a federal mandate or federal standard for how families are defined. Right. You know, I could have my family in California with particular, you know, assumptions around parentage based on relationship at the time that the child's born, and move right over to Utah, just a state away, and be worried and be at risk if you don't have an actual court order in place, which wouldn't seem necessary in the state that you're in. So we need to always kind of keep that full context in mind. And then just thinking about the, you know, the whole realm of like foster and adoption. There are discriminatory practices for queer people who want to become parents through the foster and adoption process, depending on the state, depending on the locality. Religious exemptions are allowed still. I mean, Pennsylvania just had, you know, their nice big fight not too long ago and a loss, you know, so you know, we have those concerns. And then also thinking about, you know, let's not forget about the discrimination and legal protections of queer parents who are at risk for having their children taken away. Right? That it's not just about like the middle class queer parents who are trying to go adopt, you know, these poor children left in foster care. We're talking about a system that is built on structural racism, that's highly surveils Black and Indigenous families in particular, including immigrant families, whose children are at risk of being removed from the home and placed in permanent homes that are not their own and not reunited. And it's highly likely that queer families are at high risk there and don't have significant legal protection in many locations. So, you know, we have some, a lot of legal challenges on multiple sides. Mm-hmm.
And we have some education to do. You know, I'm really feeling the call. Patrina started this by saying, you know, I don't know how you would word it. I'll make you figure that out later. You know, family, you know, making as a public health right. You know, the right to have a family. Patrina, I feel like is something you were sort of saying to us. And Bianca, you are reminding us that we are deeply engaged and complicit, and we need to educate ourselves about the systems around us and the systems we engage with, whether they affect us or how we are, you know, propping them up unwittingly in many ways. And Emma, you reminded us what you keep hearing is that the younger generations are aghast. I sort of decided I want to start a nonprofit advocacy group called Aghast. They're aghast that the stuff has not changed. So let's all end on one moment. And then I know we're going to go into some breakouts because we have some really important directions that we need to go. Yes, I know. Mia, I would love, let's make sure Mia's in a breakout group. We might all want to follow her. What's a future direction that the work needs to go? Sort of like, you know, we all have homework to do, but where's the future direction of business, research, and policy? Patrina, can I start with you? Folks looking for research projects, folks looking to fund research, where does this work need to go?
Well, I think one of the biggest challenges with research is having work like this funded.
Yes.
And supported. There are lots of folks who want to continue to investigate and create information that's useful, and getting it funded is a big challenge.
Yeah.
So I think that's number one.
Yes. Yeah. Would you like to make a plug here while we're all here for the Lesbian Health Fund?
Well, if people are interested in contributing to the Lesbian Health Fund as one way to move that needle a little bit, please go hit the donate button at LHF, because we need those dollars to continue the work.
Yeah, but the Lesbian Health Fund, I've been a long time supporter as well, supports work early stages. So it's a small amounts of money that can help you create a foundation to get some larger grants. Oh, great, Sarah, great to see that. Emma, what's your call to action? Where does this work need to go? You can name it for anyone, healthcare systems, policy, business, but maybe you want to tell the business community or the funders where to go.
Yeah, I think that like it needs to go so many places, but to really put a finer point on it and to really lean into my own like core competencies, what I'm looking at a lot is just the formation from the standpoint of like gamete donation and how to make that a much more ethical process, a much more open process, something that centers the needs of the children instead of the needs of the industry or the needs of the parents that historically really had hoped that they wouldn't need a donor of some sort. But within the queer family structure, if it is just part of what the formation process will look like, I think overhauling that both from the medical and clinical side of it, as well as the industry side of it, is just absolutely well overdue. And it's something that can be very predatory financially, and the gatekeeping methods that it can make for safe, healthy formation, but from an ethical standpoint, from a really long like arc of it for the children as they grow up into adults and even in their childhood, to have access to genetic family, to have access to medical information, to not have this be something that's like shrouded in secrecy, because in this world, in this day and age, everyone's able to get 23andMe and Ancestry DNA anyway. So why don't we just have that openness and really clear this process from the outset instead of making it an investigation that a child has to do later on in life, and also supporting the parents who are using third-party gametes to be there for their children for something that most likely they cannot personally relate to.
I do believe that children are the future. You heard it here. Bianca, what would you like to end with? Sorry, I had to be a little funny. You had to.
Well, I'll be really quick so we can
we'll jump to it.
So we can have time for our discussions. So, I agree with what Emma said. We need interventions. We need efforts at all different stages. So I'll just make a plug for the macro that before I even want to think about directly like partnerships related to reproduction, let's talk about partnerships to rethink a democracy that ensures people can help create the communities that we need, that sustain, that give people equal rights to housing, to the funding they need to live a life and to maintain the families that they have, however they came to have them. That's
perfect. Right. Yeah. Birthing the democracy comes first. You heard it here. All right. Kevin and team, take us away. What do we do now? I truly don't know what I'm supposed to do.
Well,
you mess up, Kevin.
So we are going to give you the opportunity to have a little more close conversation, some one-on-one time with some of our speakers. The way we're going to do this is we have 2 breakout rooms for you to choose from today. Bianca and Jessica will be together in one breakout room. And if you would like to join them, I'm going to put a link in the chat, which you can click. The other room.
This is not a contest. This is not a contest.
Yes.
I want to go in that room.
Well, unfortunately, Emma and Patrina, you will be in another room, and I'll put a link to that in the chat as well. Now, if you have issues, if you can't click, but it's not working for you, I'm going to remain here. So I'll get you to where you need to go so no one will be abandoned. I have some nice friends from Eidos who are going to be moderating those rooms. So when you click, you'll enter a waiting room, but my good friend Marley will be there to let you into Jessica and Bianca's room. And my good friend James will be there to help you to get into contact with Emma and Patrina. And again, if you can't click these links, if it's not working for you, just stick around. I pledge to help you. But with that, we're not going to come back together. So we're going to end here today. I'll just thank you one more time for being with us, for all you shared. I always feel incredibly lucky just to be around these folks. So I hope you all enjoyed that as well. And I'm going to let you, our speakers go. You can click those links too in the chat and we'll take you right over to your room.